live polling today, so if everyone could sign in to session 669633.
Oh my god.
Sorry for the little bit of delay. I had a meeting that went right to 1:30 and I left early. Now I'm here with you guys. The content for today's lecture is on ELC under provider status for pharmacists. You have a case study, a resource document, and a handout with slides, and an assignment Dropbox that you will be putting something into at the end of the lecture. So let's get started. Does anybody know what provider status is? Have you heard of that?
Yes, of course we've heard of it.
Has it been
No, I live under
discussed in
a
your
rock.
classes so far? It has. What do you know about it? Somebody tell me what you know about provider status.
It's not gonna happen.
You nodded.
Georgia?
What do you know about it?
Ability for pharmacists to prescribe.
Right, we're trying, well, not prescribing.
Georgia is
Get
backwards
paid
all
for
sorts
what we
when it
do.
comes to all sorts of
Let's
things.
don't say that, we can step on some big toes there. But we can prescribe in some, we're gonna look at some areas where we can prescribe. We can prescribe in some states. But the biggest thing we're trying to get done is paid for services. So we're gonna talk about how this came about, why we don't, hopefully why we will, and some of the things that you may be doing. So the legislation that's out there right now is to amend the Social Security Act. So this goes back to the 60s and 70s.
What?
When we created the Social Security Act, which also created Medicare.
669-633.
So when it first came about, we had Medicare A, and then we had Medicare B. And under Medicare B, Medicare A pays hospitals. Medicare Part B pays service providers. So when that legislation was written, pharmacists did not get in there. And so for the last 40-something years, 40 to 50 years, every time you talk to an insurance company or a government agency about paying pharmacists for cognitive services, you hear that they are not included in Medicare Part B. It goes back to that. And the reason we didn't get included back then was because we weren't considered service providers, we were considered product providers. We had a product, not a service. So that's how that happened. So what we want to be able to do is reimburse pharmacists for services. And we didn't say we want to do everybody in the world. We named there's two situations in which we want this to occur. The first is under medically underserved areas, and the other is in health profession shortage areas, and we're going to talk about those. The thing to remember, though, is even when, and I'm not saying yet, because eventually this legislation will pass, and you guys will be practicing under this legislation. Eventually, when it does pass, it will be at the federal level, and the feds will say the state will determine the scope of practice. So the state of Georgia will determine who can get paid for what by changing the Pharmacy Practice Act. Y'all are in law right now, so you know what I'm talking about with the Pharmacy Practice Act. So they will be determining what we can get paid for, and how we get paid for it, and what we have to do in order to get paid for it. There's a lot of concern with pharmacists that have been practicing for quite some time of how they'll be impacted. So you guys will probably be prepared. You may walk out, if you graduated within the last 5 years or so, whenever the legislation comes out, more than likely, there won't be any issues because you've received the education you need to provide the services that you can be reimbursed for. But pharmacists that have been out for quite some time, especially if they don't have a Form D, they may be faced with having to have additional requirements. And there's a lot of concerns about that around the state. There's a lot of initiatives going on. We're involved with working with some of those groups. So it's House Resolution 592 or Senate Bill 109, and it's called the Pharmacy and Medically Underserved Areas Enhancement Act. So that's the legislation, that's the name of it. As when I created this, let's see, this was in August. I looked at it since then, but this was the last time that the bill went through. That was the bill. But I actually checked in January, and we were at 282 representatives and this is federal. So this is at the U.S. representatives, and 53 U.S. senators are in support of it. So we have enough. That's enough people to bring it to the floor. However, somebody's got to say, I'll do it. That's how our system works. Somebody's got to We have enough people that are supporting it, but we have to get sponsors to get it to the floor. There's a lot going on in our country right now with a lot of different issues, and they haven't found the right place, and they haven't been able to get it to the floor yet, but there are enough sponsors. So hopefully, sometime during this year, it will go, because if it doesn't, then we have to start over with signing up those people again. So what does it say? And this is insurance fee, but 80% of the actual charge or 85% of a fee schedule. So who knows what I mean say when I mean a fee schedule? When I say fee schedule, what does that mean? What is a fee schedule?
I think it's like a listing of all the different services that you can provide and the payout you get for providing that service.
Correct, and that is what you see. If you have ever seen this big thing, you get at the doctor's office, they hand you this thing, and you take it to the front desk, and you have to sign that, and you give it to them, and that's how they bill your insurance. So that is the things that it has a code, and it has the service, and then it doesn't have a fee, it's just that blank line, because those are decided either by the practice and then by the insurance and what they'll reimburse and all that. So, so it's going to be whatever you actually charge for it, or it could, more than likely, it's going to be based on some type of structure through the insurance companies or through whoever is paying for the product. This legislation applies to all pharmacists that are licensed in the United States. As I said, the state will have to determine that scope of practice, so that can be very different. And some states are already proactively providing access to pharmacists to bill for these services. So like for state Medicaid or private insurance. Now, not Medicare because that's a federal program. But some states are already allowing it, and they are getting ahead of this. But what the other part of the legislation is, it has to be, it's limited to a health professional shortage area, a medically underserved area, or a medically underserved population. I'll tell you a little bit more about those, exactly how those are defined in just a moment. But this is exactly how it's worded. I mean, I took out a lot of the legalese, but this is how it's worded in the legislation. That it can be services that are provided by a pharmacist. So it can be an individually licensed pharmacist, or it can be a pharmacy provider. I know we talked about this under MTM, that I sounded very light for a minute. Okay. We talked about under MTM that currently pharmacists can't get paid for anything. Pharmacies can get paid, but not pharmacists. So this legislation will say that you, as an independent pharmacist, if you want to consult and provide this service outside of a pharmacy, you can get paid for it. Right now, we're tied to the pharmacy because only the pharmacy can get paid. It has to be something that your scope, your state law says you are legally authorized to do. It has to be a service that our state, the state of Georgia, or wherever you practice, says you can do. It also has to be a service that would be covered and furnished by a physician. So almost everything we do, physicians can also do. They don't have, supposedly they're supposed to practice under all the same pharmacy laws, but we know for a fact they hand out samples that aren't labeled and things like that. But they're supposed to do all the same things we do if they dispense. It can also be incident to a physician service. Now, we can already do that in some practice areas, and there are some pharmacists that work within physician practices, and they perform services incident to a physician's practice, or incident to the physician's care. But that reimbursement rate is very low. It's lower than what they would pay an RN to do that service. So it's one of the lowest rates of reimbursement. And also, finally, it has to be located in a health professional shortage area. We're going to look at those. A medically underserved area, or to a medically underserved population. There's those words again. So this is our area, and this tells you in the southeast where are the health professional shortage areas. Well, as you can see, there's different designations. Some designations are by county lines, some are by city lines, and then there's some overlap. So you can imagine the Atlanta area, they don't do it by the big county. They do it by actual population groups. So one area might be fine, they have plenty of providers, and then there might be another area of Atlanta or even Athens that is carved out because there's not enough providers in that area. So we have enough 239 area designations within the state of Georgia that covers over 3 million people. That means we need 612 extra providers in the state of Georgia. Now, these are statistics that are saying this is how many primary care providers they need. And remember, primary care is like family practice, internal medicine, pediatricians, and obstetrics and gynecology are also fit into that primary care. They consider those are primary care providers. So we need a minimum of 600 doctors in Georgia, or physicians, prescribers in Georgia, to meet that unmet need. So 43%, almost 44% of the people in Georgia are having their needs met. So that means over 50% of the people in Georgia in certain areas may not be getting their needs met. So that's not exactly the same as our total population, but it has to do with where they live. So over 50% of the people are not having their needs met. The way we're going to learn about provider status and what it's going to mean to you is we're going to do a case study. So there should be a case study in your informational. You pull that case study up, and we're going to work through this case study throughout the class today. So here's our case. PD is a 78-year-old white female. She has no known allergies, but she is intolerant of non-steroidal anti-inflammatory drugs. She has had difficulty swallowing large pills in the past because she's had chronic reflux and it's affected her esophagus and she has trouble swallowing. We have her height and weight, pulse, everything looks pretty good on her. She's a little on the thin side, but she's okay. She has type 2 diabetes, COPD, reflux, irritable bowel syndrome, osteoporosis, osteoarthritis, and seasonal allergies. So, what else do we know about her? Her medication. This is the big thing that we would know. We may or may not have all this information. This information would not be hard for you to get, but you may or may not have all this information. So she has, you see, this is not unusual for someone of PD's age with the number of conditions she has. As a matter of fact, this is actually a good list. This is a short list compared to a lot of patients that you may see out in practice. So here's a list of her medications. Metformin, 500 BID, omeprazole daily, alendronate daily, calcium with vitamin D twice a day, fluticasone nasal spray twice a day, daily, 2 sprays each nostril daily, a multivitamin every day, and cetirizine every day. As needed, she is on dicyclomine, and that's for stomach upset and reflux. We're not really sure why she was placed on that, but maybe it's for some kind of GI problems. She does take Tylenol for her osteoarthritis because she cannot tolerate insects. Romphenicin for problems with seasonal allergies. Diphenhydramine, hydrocortisone, and diphenhydramine cream are all for insect bites. She loves to work outside and she gets bit by insects and she has a very strong reaction, so she uses this combination to ward off any allergy and itching and things like that. Okay. Additionally, in there is the Beers criteria. So they did approve new criteria in 2018, but they have not yet been published. I went to their website. You can't get them yet without a subscription. So this is the American Geriatric Society. So the latest criteria they have is for 2015. I gave you a copy of those. So these criteria were developed, and they've been out for 2 decades now. They were developed to improve medication use in older adults by telling us things that we should watch for carefully, avoid completely, may need to be dosed differently or something like that when you're talking about older adults. So here's what I want you to do on your sheet is I want you to assess the information I just gave you for PD and all that should be, that's all that is on your sheet. I want you to take about 3 minutes and identify as many potential medication-related problems as you can and use that Beers criteria as a resource. And I am setting my timer now. So everybody has about 3 minutes to identify those and put them on and type them into the sheet. Any questions before we get started? Y'all good? Y'all know how to do this. This is what you do already.
Oh, might be. We can put it at the bottom.
I was gonna say, isn't dicyclomine, but I see it.
Oh, dang it, I changed my password the other day. I don't remember when I changed it to.
Don't APIs do something with your
Or long-term
bone?
osteoporosis.
What were you saying about bone? I thought I was looking at
Long-term PPI use because she's taking Landronate.
Um, Isn't it better to take like a bigger dose of Prosamax less often so you don't have as much irritation? She could take like 70 a week instead of 10 a day.
I didn't even know it came in 10
Yeah,
milligrams.
I mean, I think it does, but I know it comes in 70 a week, so.
Yeah. Wow, I cannot spell today. She has COPD, yet she's not taking anything soon.
Good catch.
Thanks.
Okay. There's the timer. All right, this is our first clicker question. So poll is open. How many medication-related problems did you identify?
5 or more.
Mine's not working.
3, 4, 5. Because she doesn't have it.
Austin has it open.
How's what open? This?
Yeah. Okay, there it goes. I just reloaded it.
4, 5, 6. I remember.
She needs statin. Or does she? No, she's too old and she might not need it anymore.
How old
How old
is
is
she?
she?
78.
Yeah, but once they're like that, you can like take them off because of long-term benefits. She's gonna die soon.
She's about to
She's about to croak.
hit the dust anyways.
Kind of like in that TV show, Holds Best, where they're voting on everybody. All right. 109. Oh, there we go. Come on. How many people are in this class? Going once? Going twice? So, okay. Let's see. Oh, where's my thing? Where's my crap? Oh, what? It was in there. It's not there now. Oh, well. Let's see the rest of the numbers. All right, so here's some that I identified. Alendronate, of course, we know that can cause reflux, particularly if you don't use it appropriately. She's on calcium with D and a multivitamin with D. And D is the vitamin du jour right now. I'm sure you see this in your pharmacies. How many times do you dispense 50,000 units of vitamin D? Which is a huge dose, and it's the favorite vitamin right now. In my practice, I've seen it go from C
Yeah, we do.
to E
We do.
to K to folate and all these different vitamins, and now it's vitamin D. So eventually you'll see that turn around as well. She's on 2 antihistamines, one she takes routinely and one that she takes as needed. The dicyclomine dose is probably not even a great drug for her, but it is a much higher dose for her. And diphenhydramine, particularly the topical might be okay, but you should not be using that in patients over 65. So did anybody find out why you wouldn't want to use diphenhydramine What did the sheet say? Why would you not use that in patients over 65?
I don't know, you're just not supposed to.
Highly anticholinergic.
Right? And what did that do to a patient? What risk did that cause for the patient?
It could exacerbate pre-existing confusion, dementia, those kind of things, and increase fall risk.
Right? And one of the things, it can also impact a lot of, anything the system anything that an anticholinergic can do, so urination and things like that as well. Who found something else? This is not an exhaustive list. Did you find anything else?
Yes, COPD and not on therapy.
She's not being treated for the COPD? Yes?
I was gonna say that.
Oh, you found that? Okay. So it's easy to say what's wrong with a drug list as far as what they maybe should take or should be adjusted, but also looking for things that are not there. So why is she not being treated for the COPD?
Obviously,
Okay.
I've never had an IPC
We'll see if we can
stuff
find out more
wrong
information
with
about her.
because it happens every week.
So what does pharmacy practice look like? As I mentioned earlier, the reason we didn't get on that list of providers is that we have been traditionally product-based. Everything that we get paid for is based on the product, with the exception of the new service that we get reimbursed for, which is MTM. There are a few other services that you can get reimbursed for if you have special certifications or if you practice in specific areas. But in general community pharmacy, you're not going to get paid for any type of service that's not directly related to either an MTM visit or to giving an immunization or something like that. So if you give an immunization, then you can get paid that fee for providing that information. But essentially, that's even like a dispensing fee. It's not technically like a service product provision fee. So what we hope with this is that provider status moves into a patient center, not product center. That's what we want to see happen, is that we're there to take care of patients and provide care to patients, not provide only products. Now, patients are always going to need our products, but we want it to be more about the service and making sure we're managing those products appropriately for the patient, not just about giving them the product.
Good luck
There
telling
is a joint commission of pharmacy practitioners that got together and they worked on what they want to see happen with pharmacy. And actually, they had a vision. It was for 2015. I'll show it to you in a minute. I want you to let me know what you think about it. But this is all the different organizations that got together. These are on the left are all of the different pharmacy organizations that you can be a member of for, pharmacy practice organizations. On the right are liaison members, such as ACPE that accredits our PharmD program, AACP, and then there's, believe it or not, an Alliance of State Pharmacy Associations. So there's Association of State Pharmacy Associations. So that's interesting. And then, of course, the National Association of Boards of Pharmacy that y'all will get to know very well in about a year. This is the vision that they came up with. They came up with this in 2005, and it was their vision for 2015. They're working on a new vision, but this is the one that they have did not do a good job of replacing this one. So pharmacists will be the healthcare professionals responsible for providing patient care that ensures optimal medication therapy outcomes. So they said we'll be responsible for it. And I think we already are responsible for it, but guess what? We still don't get paid for it. So we're responsible for making sure that things go right for that patient as far as their medications are, but we don't get paid for it. Oh dear. Okay. So let's go back and look at let's do a little bit more about our patient case. So here's a little bit more information you probably would not normally get. I don't know, maybe. How would you get this? So PB is, what's the one, you know what G4P4 means? What does G stand for? Well, it's Latin for gravida, but it's for gestations, you're right, but it's gravida for, and the P stands for, pardon? Para. So it's gravida for, para for. They're generic terms. That means the number of times the person, Latin terms, it's the number of times she was pregnant and the number of live births. So if you had a miscarriage, then it would be G4P3. That means you only have 3 line of births. So you may see this, you may have seen it if you're working health system, you may have already seen it. We are trying to get away from Latin, but we still see it used. But G4 means 4 pregnancies, and P4 means 4 live births. She had a hysterectomy at age 49. She suffered from chronic back pain when she was working a lot and had epidural, or before she retired, she had epidural injections for about 20 years. She has had pneumonia 3 times in the last 5 years. She was treated as an outpatient. But that is how she got the diagnosis of chronic bronchitis, because she started with the chronic bronchitis, which developed pneumonia, which led to outpatient treatment. So the diagnosis criteria for COPD, you can have 2 different types. You can have emphysema, which a lot of times is associated with smoking or environmental problems, or you can have chronic bronchitis, and that means you've had pneumonia twice in consecutive years. You were diagnosed with pneumonia, or twice within 2 years. So at 70 and 72, she had pneumonia, and that gave her the diagnosis of chronic bronchitis. So she does not have specific respiratory problems. So that may be why she's not being treated right now, because she's not having any respiratory complaints. But once you're diagnosed with something, it's like once you're diagnosed with diabetes, if you get it under control and you're not taking any medication for it, do you still have diabetes? Yes, if you had diabetes, you have it. The only reason your blood sugar is controlled right now is because you're doing it with diet and exercise. And the same thing with COPD, you may or may not have to be on something. Now, as she ages, more than likely she'll be back on some type of treatment. She also had a Shigella infection that ended up hospitalizing her for 3 days at age 77, so that was last year. These are some lab values for PB. So you got her blood glucose, pretty good, not too bad. Hemoglobin A1C is, we want it to be definitely in that range. We want it to be, for diabetes, it's going to be, you want it to be less than 6.9. I mean, that's as great as you want it to be less than 6.5. Calcium looks good, vitamin D, or albumin, everything looks to be pretty good. Now, in someone who's 78 with their serum creatinine of 0.9, what would you think about that? You think for somebody her age and weight that it's accurate? You think so? A lot of times when you get up to that age, they'll go ahead and use 1 sometimes because she has less muscle mass. So you have to have muscle mass to create creatinine. So it may not be as accurate as we get older, but she doesn't have any conditions that make us think that it's not good for her. Okay, so what do you think? Where you work, thinking of where you work right now, or if you're working or someplace that you have been, you either shadowed or worked in pharmacy, how likely is it that you would have this information? I can't get that thing. All right. Okay, let me see if I can get the chart to go up.
This poor lady don't know how to work this.
I'm sorry, y'all. They were supposed to test the system with me and we didn't get it done. So,
Oh my goodness.
maybe I
Tell
can.
him a story about McDonald's.
Nope. I don't know how to do it. I don't know how to do it with system. I'm going to give you the graphs. Sorry about that. Okay. So, what did you say? If you're in the community pharmacy, you think you'd have access to that
Sure don't.
information? What about health system pharmacy? Think it's a better chance you would have access to that information. But guess what?
What?
You could ask. Do you know how many people have a portal for their health records now? They get a report when they leave their doctor's office. Many people say, I want a copy of my labs. I keep up with all of that. So many times it's a matter of asking for it. So if you were going to provide some type of service for PD, you may have to ask for this information. Ideally, we'll eventually have a portal where you can transfer this information from our healthcare provider, but right now we don't. In some systems they do, like VA and military health systems and things like that, but not in most areas, in general practice. So some of the things we're looking at for right now is that expanded scope of practice. So we want to see pharmacists being able to do more based on the training that you have. Because I know that is probably one of the most frustrating things, and it was even for me when I got out. I was trying to do so much more than I was allowed to do when I first graduated. And it's going to be even more true for you because you're trying to do even more things. So we want to make sure that we get that expanded scope of practice. Some of the things that we can do already is managing providing immunizations. Definitely, all 50 states do that. The MTM services that we talked about before, you can do the medication therapy management and get paid for that from Medicare. And depending on the state, some states pay you to do it for Medicaid, and some states will pay you and some private insurance companies will pay you. But that's not very common in Georgia. Managing chronic disease, there's a huge push right now for pharmacists to manage diabetes. And that you have to have treated so many diabetes patients, and you have to become certified in diabetes management. But you can actually get reimbursed as a certified diabetes educator and managing diabetes as a pharmacist. That is a service that you can get paid for, particularly through private insurance. And there are some Medicare reimbursements for it as well. Therapeutic interchange. Now we're seeing a little bit of that. Has anybody had the opportunity to do that through MTM? Like if you substitute for either a generic for a brand or for another drug, they'll say if you can get them on this drug, then you get $5 or whatever. There's some programs that try to change the statin or the ACE inhibitor or something like that. That's therapeutic interchange. And then there's the third class of medications. Now in Georgia, we don't have a lot of this. We have the pharmacist dispense. What's the biggest thing you dispense? Behind the counter or from behind the counter? Food. Yes. There's several others that you can dispense. Most pharmacies won't even do it anymore. There's a lot of C5 sign-outs that have codeine and other things that are called, things like that, but most stores won't do it because as soon as they find out you do it, then there's a line out the door needing codeine. So that doesn't happen very much anymore. But Sudafed is one of the biggest ones that we dispense behind the counter. But in other states, they can do oral contraceptives. They can do therapy modification on statins. They can do we can do emergency contraception as well. So in Georgia, we can do emergency contraception. But there's not as many. But now there's a whole host of states that are creating that pharmacist dispense category of drugs, and they're expanding those drugs, particularly in those severely underserved areas. Some of the states, not small states, they're giant states, they don't have any people in, like Montana, North Dakota, South Dakota, those areas that have, they even have telepharmacy where the pharmacist can dispense the drug through a machine. We already talked about, y'all know about Medicare. So these are the providers that are listed under Medicare Part B, not pharmacists. Believe it or not, clinical social workers can bill. Qualified psychologists can bill. Physicians, PAs, NPs, psychologists, social workers, nurse midwives, and certified registered nurse anesthetists, or CRNAs. So a regular a physician anesthetist or an anesthesiologist is going to, of course, bill under physician, but CRNAs can bill under can bill directly as well. So we were not put in there. States and healthcare plans continue to cite this omission as a reason that they will not reimburse pharmacists for Part D. You know, Part D is the outpatient. So we're not asking to get paid for things that we're doing in the health system because that's always bundled anyway. That's bundled under one reimbursement. No individual department usually gets paid anyway. If there's a huge cough drug like the chemotherapy agent, a biologic, a clotbuster drug, some of those, they do get paid. They get paid a little bit extra for dispensing that or for providing those drugs in the hospital, but each individual, like that thing about every Tylenol costs $5, you don't get paid for Tylenol. So that's not a thing anymore. That hasn't been a thing since the 80s, that we get paid for each and every pill that's dispensed in the hospital. But in the community setting, Part D will not reimburse the pharmacist. As you know, they only reimburse the pharmacy. So now I like this statistic because it talks about the amount of money that's spent. This is old data. I think this may be from like 14. It's old. It's probably about 5 years old. And it takes a while to get all this stuff together. But $1.7 trillion is spent on chronic conditions. So that's 75% of our healthcare dollars go to managing chronic conditions. And you are trained to do that. Every year there are over almost $300 billion in avoidable costs due to inappropriate medication use. So what are some examples of inappropriate medication use? Someone from this side of the room. What are some examples of inappropriate medication use? Say something. Right. Continuing medicine that were started for a valid indication during a transition of care, we did not stop that medication. Taking a medication that does not have an indication. Someone from Augusta, help me an inappropriate medication use.
In regards to this patient or in general?
I don't want to stay here all day, but I will if we have to.
I don't know. Just an inappropriate, just in general.
You can look at that mayor's list and see something. What is inappropriate medication use? What are some things that patients do all the time that's inappropriate?
HTCZ.
Yes. So they're taking a medication that is not indicated for their age or for their conditions or whatever. Does everybody refill their medicines on time? So why don't they? What's the problem behind that by not refilling on time? What does that usually mean?
They're not taking it. They're taking too much.
Their disease is not controlled, but I'm talking about medication use. So if they didn't refill it on time, more than likely they didn't take it as they were supposed to.
Okay.
That's inappropriate. Not taking enough. Not taking it by the directions. Taking too much medicine. What class of drugs does that happen with?
A lot.
Opioids. Yes, thank you, opioids. So, all of these there's a whole host of things that encompass inappropriate. It's not crying, sweet state, come on.
It feels like
Inappropriate medication use really encompasses a lot. But a lot of it has to do with how they're taking the medicine. Should they be taking it? And should it be stopped and things like that. But it also
Maybe we have a
includes
test on Friday.
the other part of it is adverse
Don't
events.
hear.
And then
There's
admissions.
the real truth.
So the healthcare cost, this $100 billion is part of the $290 billion. So there's $100 billion paid for admissions due to non-adherence. So you know what adherence is. And then another $1.5 million for preventable, and this to me is probably a huge underestimate. But this is the way it was coded. So they're looking at the way it's coded when they came into the ER. So they spent, or there was 1.5 million preventable medication-related adverse events. So that means that either in the ER or somewhere in the hospital, they figured out what happened and they coded it. This is probably undercoded. There's probably more adverse events that occur than this each year. So here's those definitions I was talking about. So a medically underserved area is talking about geography. So in a certain geographic area, there's not enough primary care providers. We talked about who they are. In addition to that, there's high infant mortality, which is the entire state of Georgia. We have one of the highest infant mortality rates in the country. High poverty, we're well aware of that. We have a high poverty rate in Georgia. And a high elderly population. So our elderly population is really growing, just like it is all over the country. But one of the reasons it's growing is because now Georgia is becoming a retirement destination. So for many years, Florida was one of the most favored retirement destinations, but because of storms, taxes, lots of reasons, people are deciding that Georgia is a really good option as well. So we have a lot of, especially in the Athens area, it's kind of gone nuts in the last decade or so about the number of people who come to this area, maybe not right inside Clark County, but this area to retire. So our elderly population is going up, not just people who are living here all their lives and aging here, but people moving in at higher age. Medically underserved population. This is a specific population group with the same characteristics. It could be your elderly population, okay? So there could be a medically underserved area where there's a high population of elderly people and there's not enough health care to take care of the increased needs of that area. It could be an incarcerated population. It could be a migrant population. It could be, it just depends on the different one. It just depends on where you are, but it's a specific population. And then there's the health professional shortage area. So this is primary care, but it also includes dental and mental health. So what do you think about the state of Georgia? Do we have enough dental care providers? No, we do not. Dental care is probably one of our biggest dental and mental health care. Funny that they rhyme. That is some of our biggest problems in Georgia. We don't have enough mental health care providers, nor enough facilities that provide mental health care, especially inpatient mental health care. And a lot of this goes back to the opioid crisis, but not all of it. And then also with dental care. And dental care, that is probably one of the most controlled healthcare professions ever. They have one organization that controls controls dental education, dental certification, practice standards, everything. They are completely controlled, and they even control the number of dental schools and the number of dentists that can be admitted to dental schools. Pharmacy does not have that. We have someone that controls it, but they don't put a number on it. Dentists do. They put a number on it. They keep a shortage going because they only allow a certain number in schools. They don't want there to be too many dentists out there, and salaries go down. And I don't understand all of it, but they control all of it. That is not true with pharmacy. So, with you as a member of the healthcare team, then of course you can help to ensure appropriate use of medicines for treatment, management, and prevention. And there are many studies out there, and these are used as evidence for this legislation that show improved outcomes. There was a really great article I was going to get out there for you to read, but the schedule got changed, and I did not know that we were going to do this today writing, so I didn't make you read it. But there's also, if a pharmacist is involved, there's higher patient satisfaction. So how many of you work in health system pharmacy? Anybody working actively in health system pharmacy? Okay. Standing up and walking away. No, I don't know. Anyway, so if you work in health system pharmacy, someone has shared patient satisfaction surveys with you. That's one of the things they have to do in health system pharmacy. We don't do as much of that in community pharmacy, but we have to do it. So anytime that they put this pharmacist on the team and patients come in contact with pharmacists while they're in the hospital, their satisfaction scores with their care goes up. So it's really important to have pharmacists out there. And then definitely the reduced overall healthcare costs. That is significant. We know that when pharmacists are involved, now their pharmacy costs may go up a little bit because they're using their drugs right, but their overall healthcare costs go down because they're not having problems because they're taking their medicine right. So they don't have acute exacerbations of their disease states. And then, of course, getting the full benefit of their medications. So this comes from the Bureau of Labor Statistics, and it shows you where pharmacists are. So this was the last year for which they have data, or month, is May of 17. So in May of 17, this shows you where pharmacists are. Now those big white spots don't mean there's no pharmacists there, it just means they didn't report their data. So I think Las Vegas is in there somewhere. I know there's got to be some pharmacists in Las Vegas, and they're probably California, so for some reason the data did not get reported. But you see Alaska and Hawaii and the continental United States. So you can see us, we're in the biggest, the dark green. A lot of the area around, Atlanta, Georgia, and we might be right on the edge or whatever. But here's what I want you to do. So I want you to go to this site. You should be able to click on that link in the handout, or you can just do it yourself, find it yourself. And this is the area that I chose. I want you to choose a different area. So I want you to either find the county you're from, or your grandparents are from, or where you want to go to, or just randomly pick a place. But this shows you for Athens Clarke County, there's 240 pharmacists. As of May of 17, there were 240 pharmacists employed in Athens Clarke County. The location quotient was 1.3, and the employment per 1,000 was 2.81. That meant for each, there were 2.81 pharmacists for each 1,000 people, okay? And this was the mean salary in 2017. So the location quotient means that we are fairly well staffed in our Athens Clarke County. And if you try to find a job in Athens Clarke County, you know that, because we have the pharmacy school and we have all the faculty, so we usually do pretty good. There's not a lot of job openings for pharmacists in Athens Clarke County. But I want you to pick another county in Georgia or wherever you want to. It doesn't have to be in Georgia. If you're from another state, you can pick a county there. But I want you to find an area, and I want you to get that information. Oh, I didn't mean to open polling. So there's a link there as well. You should be able to get there. There's a lot more information in this there than what I'm asking you for, but I want you to know that it existed.
Oh, Ozma, why? What is the, what are we supposed to click on and find that?
Can you turn your mic off, please? Purse is coming.
Woohoo!
I sure did.
Where is it from?
Did you find it? Can't find the county? Can't find the website. What can you not find?
The rotation. I deserve to.
Heck
I
yeah.
thought I deserved to treat myself for doing absolutely nothing.
Do you, bro? You know how they have like those random sandpaper shops? Unfortunately.
And so the tote was originally $330, and I got it for $101.
That's a really good deal.
And then I went to the mall the very next day, and I was like, "Please, someone please stop me."
I know. I was like, I'm just going to glance.
I went because I needed to exchange something at Forever, and then I learned that they don't take back earrings. I didn't know that.
Forever 21.
Yeah.
I wonder if that's an everywhere thing.
They're like, well, we don't know if it's like tried on at home, so it's not sanitary. And I was like, but these were a gift. He's like, what do I do? I was like, I don't want them. What do you want? She was like, well, I mean, you could re-gift them. And I'm like, Okay. Thanks. It was like a pack of, like 6 pairs of studs, but I only like 2 out of the 6, and so I was like, what am I gonna do with the other 4?
You may
So I
have
was
to
thinking I could
download
just get a
the
different pack, but she was like,
data file.
fine.
What a little sassy.
Okay.
I don't know what to search to find it.
What you Pinteresting out there, girl?
Is this Tumblr?
I don't know.
Oh, she's on Pinterest. My bad, my bad. I don't have a Tumblr. What's on Tumblr?
Stupid memes.
Just memes?
Just create a zip file.
There's really inappropriate memes.
That's what
Hey,
use
I
it
have
for,
some
is
inappropriate. I
memes.
follow some inappropriate sites on Instagram, and they're like all memes. They're so funny. They're my favorites.
My favorite are like
Oh gosh, that's for everybody.
myself.
Anybody find anything? Anybody find your location quotient?
What are you talking about?
Oh, that's all the data. We don't want all the data. We just want pharmacist. Now I don't remember how I did this.
Sword.
Texas and Alaska? So why is that? No, I mean, what kind of data did you see? Nobody wants to go to Texas? So that means they have a shortage of pharmacists, absolutely. So the location quotient, you found where, does it say the whole state, or was that just, which area was that? West Texas. So yeah, that's like, yeah, way over where they have a lot of the issues with immigration and things like that. But there's also a lot of desert and reservations, Indian reservations and things like that. They do have a shortage of pharmacists. Same thing in Alaska with our native Alaska populations. There's a shortage of pharmacists in that area. So if you're really looking for a pharmacy job and you want to go somewhere where there's no income tax and unlimited natural resources, Alaska is your place. Okay.
It's not unlimited.
That one didn't work as well. And I'm gonna have to get a better link for you guys on that one.
Stop.
Okay. So we want, so what we're saying here though is that, that you want the employment, if the employment rate is greater than 2, then that usually means you've got plenty of pharmacists. If it's greater than 2 per 1,000, you've got plenty of pharmacists.
Oh my God.
Okay, there we go. So what about Georgia and the medically underserved area? So no surprise, 143 of our 159 counties are considered underserved, medically underserved. So this is older. This was done in, I think this was also in 14 or 15 when they first started working on this initiative and they created all these graphics. Maybe not quite that, about 15. But they, it's now over 12,000 pharmacists in Georgia. Okay, now some, they may not all, there's over 13,000 licensed in Georgia, but you have to maintain your license in your source state. So wherever you became licensed first, most states will require you maintain that license forever. So think carefully about that. If you know that you, and a lot of times you have to, if you do a residency, then you have to get licensed in that state. So make sure you do the best you can to determine where you want to live, because you will have to maintain that licensure. And it's not, Georgia has one of the lowest rates. It's only $200 to renew in Georgia. Some states it's $500 or more to renew. So think about that when you're, you get to put the number of states you want your score sent to and where you're going to be licensed.
That's a lot.
But there's always going to be a primary state, and most states will require you always maintain that primary license. And you have to meet all of their requirements, even if they're different from where you're currently living.
That sucks.
But what we're saying here is that the majority of this state, the majority of our state is considered a medically underserved area. So pretty much anywhere you practice if you're in a county that's not medically underserved, if you move to the next, or work in the next county, it probably is. Because the majority, over 75% of the counties in Georgia are considered medically underserved. This is another graphic they did recently, and I like this because it gives you a lot more information about what's going on in Georgia. So the estimates were, when this graphic was done, and I think this was done in 17, I pulled it down in 18, but in 17, that Georgians are spending $8.5 trillion annually on prescription medications. That's trillions, because that's millions and billions, oh, excuse me, billions, $8.5 billion. So they're spending $8.5 billion on medications every year in Georgia. On average, if a pharmacist is, the interventions that pharmacists can do for chronic conditions, they feel like is estimated to save $1,000 per person per year. Because this estimate comes from a study that was done on Medicare, saying that, you know, looking at how much we spend and how much we would say, how much is saved if the patients take their medicines like they're supposed to. So for each dollar spent on medications and filling prescriptions, you save that many more dollars. Like that, you can save like $1,000. So getting the patients involved makes a big difference, and it made a huge difference on the bottom line of Medicare. Counseling and adherence programs. Oh yeah, you can read that really good up there. Counseling and adherence programs save about $164 a patient. There's over say $440 saved for each dollar spent. So in the state of Georgia, it was more than that at a national average, but in the state of Georgia, that for each dollar you spend on pharmacist service, you could potentially save $440. I mean $4.40 for the healthcare system. So that is for like billing insurance and things like that. We're down to 17% smoking in Georgia, but it still needs to come down, and pharmacists can have a big impact on that. And then the number of people who do not take their medicines correctly that have a chronic disease. 50% of people. And this is still current data, and it's not just Georgia, but we realize that it's significant in our state because we do have a lot of chronic diseases and we have a lot of poverty. So it's even more important that they take their medicine because of access to care issues and things like that. Okay. We can't keep going, and I know you've probably already heard this, but the U.S. healthcare system cannot sustain the growth that they're seeing now. Our system cannot handle what is happening. And we've talked about this before about our aging population. The baby boomers are all coming of age, and we have an aging population, and our birth rate has declined. So we cannot sustain the growth and the needs, and we will not be able to handle the needs, the healthcare needs of our aging population in the next couple of decades. One of the things that they're looking at is called value-based purchasing, and this is where everyone works together as a team, and they get paid based on getting a patient well. You don't get paid based on filling a prescription or seeing a patient or doing a test. You get paid on outcomes. The value the patient receives, the value the system receives. There's already some models like that out there under affordable care. Have you heard of value-based purchasing? Have y'all discussed that in any of your classes? So that's the model that a lot of healthcare is going to, and there are already some models for reimbursement in the United States, but it means that you have to get somebody well. And that's what's wrong with our system. We don't have to get you well. We don't have to make sure that your disease is controlled. We just have to keep seeing you and writing prescriptions and getting them filled. That's all you have to document in a lot of cases. We've got to be able to say we're getting people well. You know about ACA. This is still there. There's a lot of rumors about it's gone, it doesn't matter. Yes, it's still there, and these requirements still have to be met. The only thing that changed recently was the individual mandate, that you're not required, you won't be taxed if you have to pay a fee if you don't have if you don't have health insurance. But when you go to get insurance, they cannot exclude you if you're sick. They have to offer minimum basic benefits like that annual exam and mammograms and other tests that are indicated for your age and your gender and your health conditions. There has to be a cap on annual expenses, so they can't say, oh, once you pay $10,000, we start paying. They can't do that. There has to be a cap on those annual expenses, out-of-pocket expenses. And then the percentage of cost can vary. So you do just have like a bronze plan, a silver plan, and a gold plan. So they offer different plans so that the higher you pay for your insurance, the lower your out-of-pocket costs are, and the more coverage you get. So those are also in place. But we are an aging population. So I like this graphic because in 2030, and you've heard us talk about baby boomers. You've heard about that. I'm a baby boomer. All of my siblings are baby boomers. But by 2030, all baby boomers will be 65. This is the largest group in the United States right now, the largest living group of people in the United States right now are baby boomers. And we are not dying. We are staying alive because y'all are keeping us alive. I don't know how, because you don't take the medicine right and don't do anything else, but we don't let you die. So we're staying alive. Now, last year, for the last 2 years, for the first time since World War II, our average life expectancy dipped.
Oh, I want to do my EKG.
Why was that? Why did the average life expectancy in the United States dip over the last 2 years?
Okay.
Decline. It was by like 0.1%. It wasn't a lot, but it did go down. Primarily opioids and overdose deaths, because those are really young people. So the life expectancy has to do with, really young people die, then it has a bigger impact on older people die. The other thing that is being blamed for some of this is the obesity epidemic. So obesity and opioids. We don't need another O. No more O's. By 2035, it is projected that older adults will outnumber children. So people over 65 will outnumber people under 18 for the first time ever in our country. You're going to be dealing with a lot of old people in your pharmacy. The other thing that's changing, though, is immigration. So there's still a lot of legal immigration occurring, a lot. And it is projected that immigration rates will actually overtake births. So that immigration will be a primary driver of population growth, more so than births. Because the number of births has declined and it's kind of stabilized. It's not going up anymore, but immigration numbers are increasing. So we'll have more new people in our country by 2030, after 2030, based on immigration, rather than new people being born. Does that make sense?
I like this band.
So you can see the changes that are occurring. Here's another graphic.
Smart.
So this is something that you can recreate for Georgia as well from the OASIS website. But it shows you what's going on. So we've had a pyramid forever. We've had a pyramid. So look at 1960. This was about the time that we got Medicare when Social Security in 64, when Medicare and Social Security came about. So you can see that we had that pyramid. And there were very few people 85 plus. But look at that. Instead of it being a pyramid, it's going to be a column. There's going to be a similar number of people at all age groups. Good news for the women. There's definitely going to be more of us alive when we get to the 85. If you want to get there. I do want to get there. You'll be taking care of me around 85 or 90, but I definitely plan on being around 100. That's my goal. But I want it to be a good life.
Because boys do stupid.
Okay, so I want y'all to take good care of me. But the reason I want you to see this is because this has a big impact on who you're going to be taking care of. So it still means, how many of your patients are under 20? Not too many. You may have a few that have a few asthma, oral contraceptives, a few things from 20 to 35, but most of the people that you see a lot of are 40 and older that come in for regular prescriptions. There may be a few things, some type 1 diabetics and things like that, but overall, as people get older, but think about your much older patients and the number you see already. That number is going to quadruple during your practice years. It's going to quadruple. So you're going to be seeing a lot more people that are a lot older. So the median age is increasing. Right now it's 38. The median age by 2060 will be 43. That will be, you know, the average age of people. So it's going to, and that's the other thing, is that there's going to be a lot more people retired and not working than working. And that gives them even more time to come see you in the pharmacy. Okay, so the things that you can do as pharmacists is, of course, those outcomes, we've talked about that, but improving the quality of life for patients. And this is why, this is some of the arguments they're using for provider status. Definitely decreasing the cost of care. The evidence has pointed to that, and you saw that in the graphic, and you can study that graphic and see why. Different states are doing different things. We've got some information. Let me see, I've got a little bit more information there. Oh, yeah. So, oh no, I deleted that slide. I want to give you some information on different states. So I know Washington State, Oregon, Montana, Tennessee. Tennessee has expanded their scope of practice. And so what they're doing, many of these states have designated pharmacists as providers. So they're ready. When that legislation passes, if you're in one of those states, they already have it carved out how you can get paid in that state. They have changed their scope of practice, and they have listed services that pharmacists can get paid for. Pharmacists have been getting paid for some things for many years. Since the 60s, pharmacists have worked in the VA system, the Department of Defense, and the Indian Health Service to do primary care and disease management, and they still do this. So if you have the opportunity to do a residency or a rotation in one of these areas, you'll get to see that pharmacists working under collaborative practice agreements with providers are already providing these services. Also, have everybody ever worked in long-term care or? Okay, good. That is a great opportunity. That's going to be another budding area. And this is the opportunities for pharmacists there are unique in that every month the chart has to be reviewed by a pharmacist. Pharmacists have to review the medication chart. So it may not even be the dispensing pharmacist. There may be a pharmacy over here that dispenses the medicine, but a consultant pharmacist from another business will come in and review the charts to make sure the medication regimen is correct. Oh, I didn't know the slide did that. Sorry. So this is what some of the services that you can already provide, that you can provide, and that's like medication management and MedRec. We're all providing those services, but we do not get paid for them. Pharmacists do medication reconciliation on transitions of care, for movement in the unit and things like that, but they do not get paid for it. So hopefully these are the services that you will get paid for moving forward with provider status. Oh, there it is. Okay. So in 2015, Washington expanded their scope of practice, and they have an entire category of drugs that they can dispense in Washington that are pharmacist only. There's some antibiotics, there's oral contraceptives, there's some drugs for other chronic diseases such as hypertension, and I can't remember, there's one other set of drugs. It may be not thyroid. There are drugs that you can dispense that's behind the, they don't have to have a prescription. They don't have to see a provider. They can only be assessed they only have to be assessed by the pharmacist. 2017, in 2017, Tennessee, and in 2019, Ohio, both signed legislation. The Ohio legislation in January was signed recognizing pharmacists as providers. So they know this is coming, and they're getting ready. So hopefully Georgia won't be far behind. I thought that I had deleted some of these slides. I'm not going to go over some of those with you. Okay, so y'all heard about the patient-centered medical home, correct?
No.
Have you heard about that? Patient-centered medical home? I know you've heard about patient-centered care. So that's really talking about where the patient has a place to go. It's where their primary care is, so they have one place to go. Instead of the patient having to keep up with all the doctors they see, one doctor keeps up with all of it. And if they get referred out, the information comes back to that doctor, and they have a whole record for that doctor. Accountable care organizations are groups of providers that work together on that value-based purchasing that we were talking about. Okay, so these are some of the services that you can already be reimbursed for. Anticoagulation therapy can only be reimbursed in ambulatory care settings associated with a health system. So that's where you have to do the INR and you manage the warfarin. Those can only be, that cannot be reimbursed in a community pharmacy. I don't know why not, but unfortunately it cannot at this time, but these others can. You saw this from when we did the MTM. Okay, let's get back to our case study. So, the pulmonologist has sent PB to you to look at her evaluation history, her immunization history, and see what she needs. So when you look it up, you see that she's been getting her flu vaccine every year. She comes to you for that. She got the PPSV 23 about 5 years ago, the traditional pneumococcal vaccine. She got a tetanus and diphtheria booster about 6 years ago. And she came in for treatment for an active case of shingles about 10 years ago, but you don't see any evidence of a vaccine. So what immunizations does PB need? If y'all know where to find those, look for the 2019 adult immunization guidelines. Google that. They're divided up by age group. So what do y'all think she needs? I know you're answering, but I can't tell and I can't.
Wait, they have to get the 23, I
It's not
thought.
up here.
Isn't it 23? Ozma, do you know? Don't they have to get
What do you
like
think?
23 now?
What? She's 13,
She needs 13? Okay.
What is TDAP?
Okay. I guess all.
She's like, you know, 6 years ago. She doesn't even, she
So TB is tetanus diphtheria. She had that. So what's the P?
Just see.
Pertussis.
How was Erin paying attention?
If PB has never had that, should she have it?
Yeah. Right? If you've never had Tdap, shouldn't you have it?
You see the recommendations? What do they say?
Erin just said that she had a
Tdap 6 years ago.
Oh. When do you get a booster? Every 10 years? Yeah.
What about shingles vaccine? She had shingles. Does she need the vaccine?
Yeah.
Yes, you can still get the vaccine. What about that other pneumococcal, the Prevnar? Should she get that? Tdap is with pertussis. So the guidelines say, I think this came out in the early 2000s, that every adult should get one Tdap booster in their life. You got that series as a child with pertussis, but there's been a rise in pertussis, and the reason the adults get it is not because they're at risk for pertussis, but because it protects people who can't take the vaccine. So children who are under a year old, who have not finished their primary series of vaccines are protected, because those are the groups that are seriously affected. People who are immune compromised or for other reasons cannot take the vaccine. They want to improve the herd immunity for pertussis to protect people who cannot be vaccinated. Okay? So she should have all of those vaccines. Why are we giving that other pneumococcal? Why did we decide to give that one? Why are we giving one's 23? Why are we giving a 13 if we already gave a 23? What'd you say? But what's different with the 13 and the 23? Yes. The 13, even though it only has left, it still has strains that were not in the 23. And we know that those are some of the strains we're seeing that still cause pneumococcal disease in older adults. So it's recommended they get both of them. Okay, very good. All right. Can we give her these vaccines as a Georgia pharmacist? Can you give all of these vaccines or not? What does Georgia law say?
What are the
Think not?
vaccines again?
They changed it a few years ago. We can give all of, we cannot give Tdap, but we can give all the others. So Tdap, she would either have to go to the health department to get a prescription, but you can give all the others. So she can get her shingles vaccine, her Prevnar vaccine. Can they give Tdap in Georgia? Huh?
Hey, it's my
And then, of
sound.
course, flu vaccine, we can give that, and we can give them
That's
meningococcal.
copyrighted, ma'am.
There we go. All right, I want to touch briefly on star ratings. How are we doing for time, so we can finish up our case?
Oh,
Doing okay. So, have you heard of star ratings? This thing's not working for me. I wanted to see what y'all were saying, but it did not work out. Have you heard of star ratings? What class did y'all talk about those in? Was it health systems or something like that?
Battery.
Maybe. So who gets a star rating? Pharmacy?
Ooh, that's hard.
Hospitals?
I always make sure that list close because I'm not gonna ever all.
The star rating is assigned to a plan. The Medicare Part D plans get those star ratings, but pharmacy has an important role in that. If we aren't doing what we're supposed to do, that it impacts the star rating. So we have an impact on star ratings, and star ratings are based on pharmacy services, but it's the plan that gets the rating. And they developed this to try to help people choose the best plan because it means that they are providing, those pharmacies are providing the most services, that they are doing things to assure the best outcomes for patients. So it's the Medicare Advantage plans, not the pharmacy. And it's a quality measure to make sure that that health plan is covering things that they should cover. And there are key areas for pharmacy. So what it's talking about is adherence. Did they take it as they were supposed to? Plus the days covered gives you that star rating. So when they're talking about, there's medication safety and medication adherence. For safety, goes back to the Beers list. And there's other lists out there for that. There's a couple of other lists for safe drug use in the elderly and the way you evaluate it, but Beers is one that's been around the longest. I know that Dr. Bland talks about another list. Y'all may have heard about that one. But there's two measures of medication safety: avoiding those high-risk medications and making sure that blood pressure patients with diabetes are on a renin-angiotensin system antagonist. So it could be, a lisinopril or losartan. It could be either one of them. So it could be a sartan or a pril. So why do you think they picked that as a measure of safety? What's safe about making sure that we treat blood pressure in patients with diabetes? How is that a safety measure? What are some of the risk factors for diabetics with high blood pressure? What are some of the things that can happen to them?
Retinopathy.
Someone from Albany, what could happen to a person with diabetes and high blood pressure that's not adequately controlled or treated?
Cardiovascular disease.
Right, absolutely, probably the number one thing. What else can happen? Something else.
Retinopathy.
Kidney failure.
That's another big one, and we know that those RAS antagonists protect the cardiovascular system and they protect the kidneys. So, and another thing is it protects from amputation. So those are the big three things, or I guess four: heart attack and stroke, dialysis, and amputation. Those are the things that you worry about. Now, if you start talking to a man with diabetes and high blood pressure, another thing you can tell them, and this is the way I finally got through to a patient to be adherent, was that it can cause erectile dysfunction.
So sweet.
So those medicines are really expensive. It's a whole lot cheaper to take lisinopril and keep your blood pressure controlled. You got to find the message that
I guess
fits
that's one
your
way to do
patient.
it.
So whatever works with the patient.
She
So
said
then the other
it's a
three
whole lot
measures are
cheaper
medication
to take
adherence.
lisinopril than like
Or this is how, did they have the medicine in their house on the day they needed to take it? Now, it doesn't say they took it. It just said they had it. We want to make sure proportion of days covered means they got their refills on time. So there's no guarantee that they took it, but it was in the house. So they picked it up. That's the good thing. So they look at 3 different types of drugs. They look at cholesterol and statins for cholesterol, for diabetes. There's 4 classes of oral meds. Insulins are not in here. They look at oral medications. And then for hypertension, once again, those RAS antagonists. So they look at those. So those are a big one. They actually count in 2 areas. They count for adherence and they count for safety. So those drugs have a lot of evidence behind them to improve outcomes. So then they look at those 2 things and they put them together to come up with a star rating. That's why they will ask you, like when you did MTM, and said, well, I see this patient's a diabetic. Are they on an RAS drug? They will ask you that. And if they have diabetes and high blood pressure and they're not on an RAS, then that's a ding on that plan. They're going to go back to the prescriber and talk to them about that patient, that they should be on that drug. Okay. So here's the statistic. For every 1% increase in the number of prescriptions filled, Medicare spending drops by 0.2%. And I'm going to look at the actual statistic on that to tell you what it is. Because, so this equated in 2013, we spent $585 billion on Medicare spending. So this meant that we saved $1.17 billion for each 1% increase in prescriptions filled. 1% increase. So if you fill 1% of more prescriptions are filled in a Medicare population, we can save $1 billion. That's how important it is to take medication to prevent disease progression. It keeps them out of the hospital. There's less ER visits, less admissions, and less doctor visits. Okay. So let's wrap up the case, because I want you to have some time to finish that up. All right, so a little bit more about PB. She lives in a rural, underserved area. So she's one of the people that's in that area in Georgia that's underserved. She's a retired nurse. She's married. She's been widowed twice, so she's on husband number 3. She does not smoke, but she doesn't divorce him. She buries him. She does not smoke. She reports no illicit drug use. She does say she drinks wine, about a glass every night while she's fixing supper, except when she goes dancing on Saturday night, and she may drink more. And this is the kind of things that people will tell you when you talk to them about these things.
That's pretty impressive.
Her family history. Her father died of a heart attack at age 61. Her mother died of complications of a stroke at age 93. She has 3 siblings. They're all living and no serious chronic illness. She had a daughter that passed away from scleroderma, which is an autoimmune disease. She has a son with seizure disorder and a daughter with lupus and fibromyalgia. So the reason you want to find out about, why would you want to find out about someone's children? So her brothers and sisters are all fairly healthy, but she's got children that have problems. What would be the importance of knowing that for a patient? How would that help you in taking care of her? What do you think?
I may eventually be her caretaker.
They could be her caretaker. But it also helps you to have something, I mean, these are the things that people are more, when people, especially when they get older and they have concerns, they may ask you about that. They may say, well, they put my son on this, and they might ask you about their medicine. But it also could, from a mental health or a social standpoint, right, the social standpoint, will she have someone to help her if she needs it? Would these people be able to take care of her? And there's a growing number of people, older people, who are actually the caregivers in their family for children and grandchildren. So many times you're dealing with that social aspect of it, and you're not understanding why they're not picking up their medicine on time, or why they're not doing this, or why they are taking medicine every other day. They may not have enough money. They may not have transportation. There's a variety of reasons. So knowing about a person's social history will help you understand some of the things they're going through, and maybe help find ways that you can make sure that they do get their medicine. Okay. So, this is the last few questions. I'm not gonna, since this isn't working, I want you just to do it on your sheet. So let me pull up, I think that was the last one, yeah. Let me pull up the sheet. So have y'all been able to answer the questions so far? Okay, so I've given all the information that was on the slides is here. And these are the lab values that she gave you. And many times they do have this, and they may even ask you on occasion. I have had patients ask me about something. They said this, and any patient with diabetes should know their hemoglobin A1C. So if you ask them what that is and they can't tell you, then you should say, well, we need to know that. That's an important number for you to know. That should be a number like knowing, most people know their blood pressure. You ask them, don't they? They can tell you if it's high or what it is. Usually they can give you a good estimate. Maybe even blood sugar, but that hemoglobin A1C is an important number for them to know. So the last three questions are, I want you to look at the laboratory values and tell me if you have any recommendations on that. I want you to look at her family history and see if you think any other recommendations are should be made for her based on her family history. And a good place to look at for information like that is the U.S. Preventative Services Task Force. They have an app. You can put in your age and your gender, and it'll ask you, do you smoke, and a couple of other things, and then it'll tell you what you should consider, about chronic diseases and things like that. It'll tell you what you should consider as treatment based on that. What types of therapy and screenings you should have. And then what about lifestyle modifications? Do you have any recommendations for PV?
Hey, Dr. Bumwalter, just to clarify, does the patient drink more or less when she goes dancing?
It was my impression that she drank more, the way she said it.
Okay, perfect, thank you.
Yeah. And so one of the things and I think we talked about this in NPM, but if a patient says, I drink 1 glass of wine, then that's usually pretty good. But now if they start having cognitive decline, that's one of the first things we forget. The glass of wine we're drinking is always our first glass. I had a great aunt who had Alzheimer's, and she would drink 2 bourbon and water at bed in the evening. And it did not matter how much bourbon she drank, it was always her second one. She would, every time you would say, I said, are you going to have another one? She said, this is only my second one. She'd be pouring it. This is only my second one. And when I was taking care of her, we were getting up to 4 and 5, I was like, something's got to happen. So you got to think about that in cognitive decline. But usually, so you got to take it, if she says she drinks more, you might would actually ask that too. How much would you drink, when you were dancing? Depends on how long I stayed. Or how long I danced, whatever. But alcohol use definitely needs to be evaluated in older populations.
Few roads. There's a pediatrician here in Augusta. Oh, it's a voice.
Maybe if they die, you can take a medical license and take over their practice, and they won't find out for 10 years. Like a Walgreens person.
Yeah, it is. Her nose is whistling.
It's a trial from light.
Oh, goodness.
Oh my gosh.
No, I wouldn't go for the blue. That's
already wrote it.
Oh.
Where'd you write it?
At the bottom. I said Fosamax.
Okay, we'll give you, how are y'all doing for time? Need a couple more minutes?
Oh.
Put our names at the top.
Wait, I thought she said she wasn't. I thought we said she wasn't a candidate for KDAP.
She is supposed to be tested.
Yeah, for in case like there's like little babies
Oh.
in her life.
But didn't she have it since she was there? Or did she not have it?
Well, she had a booster, but you have to get a booster. You have to get it like anytime someone has a baby.
Where are you going?
Okay.
Oh. No, where we used to go here every year, me and my friends.
So what about looking at those labs? Do you have any recommendations?
But then they sold the cabin, so now I'm just daydreaming.
She probably needs more protein in her diet.
Her fun.
Why do you think that? Her albumin is low. How does albumin, what's the relationship between albumin and calcium?
I got you, Austin.
If you don't know, Google it.
It's worth a Google.
Correctly.
Yeah, don't. Yeah,
Correct the
you have to
calcium?
correct something.
Sorry, calcium's probably high.
She does have low protein.
Ooh. What was that?
What's her albumin? Kendall, what's her albumin?
3.8.
Is that good or bad?
0.2. What's her serum calcium?
Is it 8.9? 8.9, yeah.
So what do you think about her weight? Her height and weight, is she average weight, underweight, overweight? Anybody find the relationship between calcium and serum albumin?
remember you for 14 days.
I did.
Have you already used global
I
RPA?
guess it's just been up for 14 days.
Is it actually for her
They
Chad's
had
mask?
that.
Her Chad's mask? Is it?
Yeah, so she's female, she's over 75, and she's diabetes, so it's 4.
No, the reason I'm asking because you said like is like 4. So.
It is 4, yeah.
Okay.
All right, what else are your recommendations on labs? Anybody else have any other recommendations?
Should we cut her metformin dose in half so she's like 40
Her protein is low,
mils per
so she
minute?
needs to increase the protein in her diet.
Well,
Because like,
metformin's based off of EGFR.
hmm?
Isn't metformin just based off
Yeah.
EGFR?
But
What's the difference?
What about her family history? Did you find anything that might suggest she needed additional therapy or changes in therapy based on her family history?
Could we put her on aspirin 81 milligrams since she's got family history of cardiovascular stroke and stuff like that?
Excellent. She probably should be on an aspirin. Now, she had problems with NSAID, so, and that may be an issue with her, and that may be why she's not on it, but it should definitely, that's a conversation that should happen because at her age. Now, it would be primary prevention, and there's some evidence about primary prevention and aspirin, and the adverse effects potentially outweigh the benefits, but there was a significant cardiovascular risk for her. Anything else? Anything else from her family history that... So you notice her mother had COPD as well. And that her mother had the stroke. So her father had the heart attack and her mother had the stroke. So it should definitely be looked into. What about lifestyle modifications? What's missing from the information I gave you on PB? On her social history and her information. What did you not see anywhere? She goes dancing.
Exercise?
Right. There's no mention of any type of physical activity except she does say she goes dancing. So that would definitely be something, because we know, especially in chronic disease, that physical activity is important throughout the lifetime. Now it's got to be something that's safe for the person, and she does have osteoporosis, so she would want to be careful. She wouldn't want to do anything high impact or anything like that, but she does need to, even walking is excellent for osteoporosis, because when you're doing weight-bearing exercise, it's going to improve bone density. So what would you recommend for her?
Does she need protein?
her bones.
What might be a recommendation for PB?
I'm gonna delete it.
Huh?
I'm gonna delete this.
Think way back to first year and what kind of physical activity might be recommended? And how much and how often?
Water aerobics.
We could recommend walking or some other low-impact exercise.
Walking would probably be one of the best things for
Does she
her.
say anything about
And dancing is good
besides-
too, because it is
She
weight
just
bearing.
always
So
does
how
the
often should
relationship.
she walk?
I just found the correct calcium.
150
It's still
minutes.
fine.
30 minutes, 3 times a week. That would be an excellent recommendation for her.
Whatever.
Do y'all have any other recommendations for
No,
PB?
can we leave?
She might could drink more water. She seems a little dehydrated.
That may be the reason that for some of her labs, absolutely, that she could be dehydrated. You're right. So, and that's another thing that she, we didn't really talk about her. It might be with her albumin and her weight. It might be a good thing to even have that in conversation about her diet. So that's also missing. We didn't really talk about what kind of diet she consumes and her exercise. So those two things would definitely help you to provide that, to get a better picture of her. Very good. What about her medicines? Did we recommend any changes? We talked about the things that were causing problems. So what would you do with her medicine? Would you stop any of her current medicines? Would you recommend stopping any or modifying any of them?
Benadryl.
She could stop the diphenhydramine oral, that's PRN.
Definitely stop the diphenhydramine, yes. The dicyclomine, I mean, what is she taking that for? She doesn't have any, she's not saying she has any conditions where, what is dicyclomine indicated for?
Isn't it IBS?
Yeah, it says she has IBS.
Think she's taking it for the IBS?
Yeah, we do.
Is it effective for IBS?
Yes. I thought it was.
So that may be one of those we were talking about. She's
No,
taking a medicine that may not really be effective for her indication.
Wait,
What
that's
about
what
the
it
It
lefenacin?
treats the like
It-
cramp,
What do y'all know
cramping
about?
and stuff.
but
Yeah.
she needs to be on something that
Well,
makes it more
venison.
regular so that she doesn't like Linzess or
Is it effective?
something real expensive. Or something.
What's better than water? Water. Very good. Okay. The other part of the story is with the hydrocortisone and diphenhydramine is if she gets an insect, it's usually like ant bites from working in her garden. So that's a good thing that she does do, and it should be on there that you would find that out if you're like, well, what kind of activities do you do? Well, I work in my garden, and that's how she gets the insect bites. And she does her own little concoction because she's a retired nurse. She started nursing when nurses didn't really have pharmacists in the hospital. And they would mix their own medicines and mix stuff together and make their own potions, believe it or not. And she would mix the different creams together. Okay. So we wouldn't really mess with any of her routine medicines that she takes on a daily basis, but what counseling points might you provide for her?
Would you recommend changing to an H2RA since she has osteoporosis?
Recommend doing what?
Changing to an H2RA, like ranitidine?
That might be a better idea. And believe it or not, there's studies out there. Omeprazole is being tied to a lot of problems. The microbiome, the gut, irritable bowel, it's been tied to problems with the gut and disrupting the microbiome. It has actually led to, there's studies linking it to cognitive decline in older patients. That drug was never designed to be taken forever. So omeprazole was never designed to be taken forever. But she does have reflux, so if you did put her on H2RA, what else might you tell her? If you recommended stopping that and put her on H2RA, what else might you tell her? What is the drug on here that really has very specific dosing requirements and administration requirements?
Alendronate.
Yes, so what might you tell her about the alendronate?
Don't lie down.
Take it on an empty stomach and make sure that you're sitting up for at least 30 minutes after you take it.
Right. And I mean, one of the things, and I saw this happen personally, was they would go and get in a recliner. They would get up and take it, put the coffee on, and go get in a recliner and just not lay all the way down. But when you say sit up, I usually don't tell them to sit up. I usually say you need to take this when you can walk around. Because before you know it, you're sitting down, then you're lounging and whatever. So this patient was actually, she would lay down and would recline in the recliner, and it was causing serious reflux. And because they said sit up, and she considered that sitting up. So make sure they understand if you say sit up, you have to be sitting straight up in a chair. Even better, walk around, while the coffee's making, just walk around and do some stuff and try definitely don't even lean back while you're taking this drug. It depends on the person, but some people have had serious problems. Okay. All right, so we're getting finished a little bit early. Are y'all okay with that?
Yeah.
So get this sheet, finish up your sheet, get it in the Dropbox before midnight tonight. And,
One per
you have
group?
any questions?
One per group, is it?
Are we done?
Will y'all get ready?
Is it one for every group or one for every person?
It's one per person. This is the individual letter, yeah. So one per person.
Can we all just
Do
submit
the
the
same
same?
way?
Oh, well, we like,
No, this is an individual assignment.
Too bad.
Okay,
Okay.
well, we'll all
It
just,
won't take you long to put yours in, so individual assignment, because I didn't set it up as a group box, so individual assignment.
well, can you set it up as a group box?
I apologize, I should have clarified that at the beginning.
Yeah. Whatever. I'm just gonna delete everyone else's name and turn it the same shit.
Yeah.
So get that in there before midnight tonight, and you guys get ready, because you're gonna hear a lot more about provider status in the next coming months, so thank you.
what time's have to be in the Dropbox?
Midnight.